The use of fluids is ubiquitous in the ICU environment. Fluids are used for maintenance of normal body homeostasis, as a vehicle for delivering interventions, and for correcting fluid balance disturbances. Given the widespread use of these fluids, a thorough understanding of the composition of commonly available fluid preparations is very important. In this module, we'll review the composition of these essential products. A variety of fluids are available for use. Each have their own specific benefits, harms, and clinical indications. An understanding of these features is important before you prescribe fluid therapy. Crystalloids refer to a group of fluids that are aqueous solutions of mineral salts or electrolytes. Sodium chloride is the predominant salt used, similar to the composition of the extracellular fluid. They may also contain other small cations such as potassium, magnesium and calcium, and anions such as bicarbonate, acetate and lactate. Crystalloids are presented in a variety of concentrations and can be hypotonic, normotonic or even hypertonic relative to normal ECF values. 5% dextrose is a commonly available solution. Effectively a mechanism for giving pure water, it is designed with the purpose of being isotonic with blood, allowing it to be infused without inducing significant hemolysis, a concept that's further explained in the fluid physiology module. Once infused, the dextrose is rapidly removed from the circulation by uptake into liver and muscle. Consequently, 5% dextrose is an excellent vehicle for the delivery of free water to the patient. Water, as we've discussed in the physiology lecture, is distributed across the total body water space, as it is freely diffusible along osmotic gradients. As a result, only a tiny fraction, in the order of 8%, remains in the vascular tree shortly after administration. This makes it an ineffective resuscitation fluid, and it is likely to be harmful as it causes significant electrolyte dilution if given quickly. It is worth noting that dextrose is also a source of calories. 5% dextrose contains 278 millimoles per litre, or 50 grams per litre, of dextrose, which equates to 200 calories per litre. This is approximately 10% of the daily calorie requirement for a 70 kilogram male. There are a number of risks of 5% dextrose administration. Hyponatremia is a dangerous complication of free water administration, largely due to the risks of cerebral edema and central pontine myelinolysis. Hyponatremia is of greatest concern when the patient's ability to excrete free water is limited, including those on diuretics, with poor renal function, those who have high levels of antidiuretic hormone, for example trauma patients, postoperative patients and those with sepsis, the extremes of age, and certain drugs such as narcotics and non-steroidal anti-inflammatory drugs. Rapid intracellular water shifts can occur, most important being cerebral edema. And hypoglycemia. This is usually not a concern when low concentrations such as 5% are given slowly in patients with normal hepatic function. Normal saline is a 0.9% preparation of sodium chloride solution, equivalent to 154 millimoles per litre of sodium and chloride. If sodium chloride completely dissociated in solution, the expected osmolality would be 2 times 154 or 308 milliosmoles per kilo. However, when measured directly by freezing point depression method, the tonicity of normal saline is 284 milliosmoles per kilo because a small percentage of sodium chloride remains non-dissociated in water. As such, this fits nicely with the normal range of blood osmolality of 270 to 290 milliosmoles per litre. The term normal is often misunderstood. A normal solution is a physiochemistry term that describes a solution where 1 mole, or 1 gram weight equivalent, of the salt is dissolved in 1 kilo of water. In the case of sodium chloride, this would equate to just over 58 grams of salt per litre of water. This is clearly not the case with so-called normal saline, which actually derives its name from red cell lysis studies performed in the 1880s, which suggested that the concentration of salt in the blood was 0.9%. Hence it is normal when compared with extracellular fluid. Interestingly though, further research has determined this is not the case, but this is beyond the scope of this video. The primary advantage of saline, and crystalloid solutions in general, is cost. They are significantly cheaper than alternatives to produce, distribute, store and administer. It is known that because sodium distributes freely across the extracellular fluid space, that within a few hours 80% of crystalloids eventually spill out over into the interstitial space. This creates 2 effects. The first is that the fluid infused will not expand the vascular compartment to the same degree as the volume infused. This has been seen as a significant negative for its role in resuscitation. For example, if 1 litre was infused, within a couple of hours it would be expected that only 200 to 250 mils would remain in the vascular tree. However, this is not necessarily undesirable. As discussed in the physiology video, intravascular depletion does not occur in isolation. Fluid will be recruited from the interstitial space and then from the intracellular space to partly replete the vascular space. For this reason, this tendency of crystalloids to spill over into the interstitial space is not completely unwanted. The second effect is that it can increase the interstitial fluid volume quite significantly. It may dilute interstitial space concentrations of ions and other molecules, slow oxygen transfer between capillary and tissue, and can interrupt normal tissue processes as a result. This manifests clinically as tissue edema, which contributes to organ dysfunction. In addition to tissue edema, other complications can exist. Dr. John Kellum is a professor of critical care medicine at the University of Pittsburgh.
As early as the late 18th century, there was already an understanding that saline or other unbalanced crystalloid solutions could produce metabolic acidosis, but was very little appreciation or at least agreement as to how this occurs.
The problem he describes is the now well-recognised complication of metabolic acidosis. This is an inherent complication of large volumes of fluids with a lower strong iron difference than that of blood, usually expected to be about 40 in health. Normal saline has a strong iron difference of 0, and thus can cause quite marked non-anion gap metabolic acidosis when large volumes are given quickly.
Way to sort of think about it is that in normal blood plasma, you have a balance of different constituents, charge molecules on both proteins as well as electrolytes. If you dilute that blood plasma with a solution that has equal positive and negative charges, equal anions and cations, the blood plasma will shift more and more toward that neutral position, and ultimately that will produce a blood pH that is closer to 7.0 than it is to 7.4.
Often the term hyperchloremic metabolic acidosis is used. It is important, though, says Kellum, to realise that the cause of the acidosis is the fall in strong iron difference, not the chloride or even the pH of the fluid itself.
It's a little bit of a misnomer, though, this idea of dilutional acidosis, because that suggests that whatever you dilute the blood with, it's somehow the pH of the solution that matters. And what matters is the electrolyte composition of the solution, not the pH.
The chloride rises because its concentration is higher in normal saline than in plasma. However, if low chloride concentration solutions with a strong ion difference of 0 were infused, then chloride might actually fall, but an acidosis would still develop. Consequently, some authorities reject the term hyperchloremic metabolic acidosis because it inappropriately suggests that the chloride itself is responsible. But it's not as straightforward as that. John Kellum explains.
So the reason that the effect that you would have hypothesized by merely changing the strong ion difference of the plasma towards 0 with dilution, that effect on blood pH is not as significant as one would have anticipated because the effect is mitigated by simultaneously, as you say, diluting the weak acids. But because weak acids are weak and have less of an effect than the strong ions that you're diluting, the ultimate balance, if you will, between diluting a weak acid and inducing acidosis from changing the strong ion difference will favor acidosis. It just won't be quite as severe as one might have anticipated. A little note of caution, though, there, and that is that critically ill patients frequently have very reduced buffer capacity. So their albumin, and it's albumin that's the major constituent because it's the charged portion of the proteins. The plasma proteins can have a variety of different charges, but it's the albumin that is sort of consistently negatively charged. So when you have very low albumin concentration, which is typical of many of our critically ill patients, the ability to mitigate that effect that we've just talked about is reduced, and so you tend to see a somewhat larger effect of producing metabolic acidosis when you give saline in large quantities to critically ill patients.
This concept is important. It would be easy to assume that the strong ion difference of the ideal resuscitation fluid should be about 40 millimoles per litre, just like extracellular fluid. However, this alkalinising effect of the dilution of extracellular electrolytes and proteins means that it's somewhere in the middle. Computer models and laboratory trials suggest this figure is around 24. This concept, explained by Stewart's theory, is discussed in more detail in the arterial blood gas module. The impact of this acidosis remains unclear.
I do think it's worth noting that the human body defends a plasma pH of 7.4 with a great deal of tenacity, which should probably tell us something. We know that in vitro that a variety of enzymes are affected because the pH. These proteins are obviously sensitive to the pH, and their PKs are affected by the prevailing acid-base status. There are a number of basic science evidence that suggests that a variety of enzyme systems and proteins are affected by changes in pH that can occur in the physiologic range. So I would describe all that as being fairly strong circumstantial evidence that blood pH is important.
Acidosis has also been associated with pro-inflammatory changes resulting in perturbations of cardiac, respiratory, renal, splanchnic and coagulation systems, and high-volume saline resuscitation is associated with renal injury and immune dysfunction.
I think until recently we've not really had a lot of good data, and I think the reason for that comes from the fact that patients that tend to have significant acid-base abnormalities also tend to have significant underlying abnormalities, many of which have caused the acidosis in the first place. And so it's difficult sometimes, I think, to tease out the guilt by association, which may be part of it, versus a direct causal link between changes in acid-base balance to outcomes.
Despite the occurrence of an acidosis, many reviews have found that the clinical effects are rarely profound. Base excess rarely drops below minus 10 millimoles per litre, and with appropriate respiratory compensation, pH remains above 7.30 in most cases. However, the significance may be important where there are other processes at play that result in acidosis, compounding their effect. the high chloride levels found in normal saline are now being associated with increased patient harm too. Dr. Ronaldo Bellomo is a leading researcher in critical care nephrology.
The major mechanism that is proposed on the basis of experimental animal data and on the basis of the observational data in the control studies in human beings where renal perfusion to the cortex was measured by MRI-based arterial spin labeling techniques is that there is a decreased renal blood flow and renal vasoconstriction.
In one study, the abolition of all high chloride fluids in a single tertiary ICU in a before and after study demonstrated significant reduction in acute kidney injury. These findings have been replicated in post-operative surgical patients. The uncontrolled nature of these studies renders the conclusions to hypothesis-generating only. As to how chloride can cause these effects, researchers are only beginning to understand using animal models.
There are two lines of potential explanation in animal experiments. One is that chloride administration may increase the sensitivity of the afferent arteriole to the vasoconstrictive effect of thromboxane. And the other one is that the administration of chloride may deliver a large amount of chloride to the tubules and then in particular to the loop of Henle, and the chloride load would then activate the macula densa, which is a sensor for chloride, which in turn would respond to it by inducing vasoconstriction of the afferent arteriole.
These prospective mechanisms, he says, need to be validated in humans. This concept is discussed in more detail in the video, The Problem with Chloride. Diluted forms of saline are available. Similar to 5% dextrose, these fluids are sources of free water with varying concentrations of electrolytes. To remain isotonic with blood, they are mixed with dextrose solutions so that their effective osmolality is around 150 milliosmoles per litre. Examples include 4% dextrose with 0.18% saline, otherwise known as 4% and a fifth, or 3% dextrose with a third normal saline. In essence, these forms allow for the delivery of fixed quantities of electrolytes for maintenance purposes and proportionately more water. As such, they are primarily used as maintenance fluids and are inappropriate for resuscitation, except in highly specific circumstances where free water loss is present. When used, careful monitoring of fluid balance and electrolyte status is necessary. Hypertonic solutions of sodium chloride exist and include 3%, 7% and 20% concentrations. Hypertonic solutions are used either as volume expanders using the lower concentrations or to rapidly and specifically increase serum sodium concentration using the higher concentrations. Hypertonic solutions have been used for rapid fluid expansion as they encourage osmotic shifts into the vascular space. They've been used in trauma, particularly pre-hospital and in combat situations, but evidence supporting widespread use for this purpose is lacking. These fluids have also been used in traumatic brain injury to maximise cerebral perfusion. In theory, creating a relatively hypertonic extracellular fluid can reduce intracellular swelling, reducing cerebral edema and therefore intracranial pressure. Hypertonic saline is becoming very popular for this indication, though direct comparisons with placebo or mannitol are still lacking. Hypertonic solutions can be dangerous to use, and expert guidance is very important. For more information on how to use hypertonic saline, please refer to our video on hyponatremia in the electrolyte module. Since the strong ion difference of all these solutions is zero, they can all, in theory, cause metabolic acidosis if given in sufficient quantities. The more that is given, and the more concentrated they are, the more quickly this will be generated. The recognition that large volumes of solutions with small strong ion differences, such as normal saline, would lead to a metabolic acidosis, resulted in efforts to redesign fluids to suit this purpose. By increasing the strong ion difference of these fluids, larger volumes can be given without causing the pH to fall. John Kellum again.
So there's an abundance of evidence to support the effects of saline versus balanced electrolyte solutions on acid base, and there's really very little question that shows that the metabolic acidosis occurring with saline can be mitigated by giving a balanced electrolyte solution.
The normal strong ion difference of plasma is around 40 milliequivalents per litre. Thus, solutions with an SID less than 40 will tend to reduce the pH. As discussed previously though, dilution of extracellular space results in lower concentrations of total acid, known as A-tote. This has a somewhat alkalinising effect by diluting out the ECF electrolytes and proteins, partially counterbalancing the acidifying effect of the SID reduction. Therefore, the ideal SID of a resuscitation fluid to maintain a static pH is actually 24 milliequivalents per litre. However, electrical neutrality requires each positively charged ion to be offset by a negative one. Thus, reducing the chloride concentration in a resuscitation fluid while maintaining the sodium level requires the addition of a negatively charged ion. Bicarbonate would be ideal, but is problematic for various reasons, and it is harder to manufacture and distribute. Alternative anions are therefore required. Organic acids that are rapidly metabolised, such as lactate, malate, gluconate, citrate and acetate, have been used. Though these are strong ions, technically resulting in a pre-infusion SID of 0, because they are rapidly metabolised, they leave an effective gap, thereby reducing the impact on the serum SID. In summary, the ability of the organic ion to disappear rapidly, generating a fluid with an SID, is what is responsible for preventing the acidosis. Sadly though, some of these anions have toxic complications which preclude their use in large volumes. Lactate has been commonly used. It is readily metabolised by the liver and can be infused in rates of up to 100 millimoles per hour in patients with normal hepatic function before it starts to accumulate. This is affected dramatically in illness though, where liver function and perfusion can be drastically reduced. Lactate accumulation can interfere with glucose control and ATP generation, and so on its own has limitations as a resuscitation fluid in large quantities. Acetate is significantly better tolerated as it is metabolised faster and partly by extrahepatic sources. However, prolonged exposure to high levels can cause renal dysfunction, myocardial depression, neurological change, and electrolyte disturbances. Citrate has been used, but toxicity is problematic as it complexes important cations such as calcium and magnesium and results in dysfunction of excitable cells and anticoagulation. Gluconate is another organic anion that has found favour in recent times and is found, along with acetate, in Plasma-Lyte 148. The constitution of this and some other balanced crystalloids is shown here. As previously discussed, the ideal SID for a resuscitation fluid is around 24 millimoles per litre. Fluids with an SID lower than the blood SID, such as normal saline, will reduce the pH of the blood. In contrast, those with higher SID than blood, such as Ringer's solution, Hartmann's, Plasma-Lyte 148 and Isolite E, will result in a relative alkalosis. The major benefit of balanced solutions is the reduction of chloride. This may actually represent the true reason for their benefit. More information on this can be found in the video, The Problem with Chloride. Many of these solutions are hypotonic relative to extracellular fluid, which has been suggested as a potential complication. The effect of these solutions on clinical outcomes remains to be determined.
I guess my view on that is that given the preponderance of evidence we have from both observational studies and animal studies, when we're talking about a patient safety issue and one that we can completely avoid with by simply not giving large quantities of normal saline and other unbalanced solutions, it's not clear to me that we need randomized clinical trial evidence when these alternatives are available.
But not all agree, with an RCT appearing just around the corner. Leading fluid researcher John Myberg.
In the US alone, 200 million litres of saline are given to patients and is the fluid of choice across the world. So therefore, if you accept that saline is the industrial standard across the world driven by clinicians in the absence of evidence, and there appears to be an emerging trend, particularly in our country, to use balanced. In the absence of evidence, there is the same imperative to do a trial along the lines of safe and chest to determine its safety.
Hartmann's solution, or compound sodium lactate, was introduced into practice to overcome saline-induced acidosis. It is very similar to another commercially available fluid, lactated Ringer's solution. Like normal saline, the osmolality of Hartmann's solution is lower than that would be estimated from calculating it from its constituents due to incomplete ionisation. When measured by freezing point depression methods, the osmolality is closer to 259 milliosmoles per kilo, significantly lower than the normal range for human plasma. Given that even mildly hypotonic fluids such as Hartmann's can result in significant perturbations of ECF osmolality when given in large quantities in resuscitation, this may be important. This can theoretically result in deleterious consequences such as worsening of cerebral edema in brain-injured patients. Plasma-Lyte 148 is another balanced electrolyte solution. It has found favour in recent years, particularly in anaesthesia, due to the belief that its impact on reducing saline-induced acidosis has a meaningful impact on outcome. The calculated osmolality of 298 milliosmoles per kilo, also reported in the product information, puts it in the isotonic range. However, like saline and Hartmann's mentioned earlier, its actual osmolality may well be less than the normal range of blood. Plasma-Lyte 148 has an SID of 50, significantly higher than the 24 calculated for the ideal resuscitation fluid, and thus has an alkalinising effect on the blood. Severe liver dysfunction may reduce clearance of gluconate and acetate, leading to potential toxic effects.